We're going to look at the digestive system. So the digestive system itself is essentially a disassembly line. And so it's going to take all of the macronutrients that you're taking in and disassemble them down into absorbable nutrients that we can get from the lining of the digestive tract and into the bloodstream of the body. And so we're going to have to break everything down. We do this both mechanically as well as chemically. So we have mechanical and chemical digestion. So we're going to break down everything that is there until we have something that we can absorb into the bloodstream. Anything that is left over becomes waste and gets defecated out of the system itself. As we look at the digestive tract itself, we have essentially the entire tract, which is essentially just all of the open space that is within the digestive tract itself. Comes down, we come into the stomach, go through all of the small intestines, through the large intestines, and then out of the body. And so that makes up the digestive organs themselves. And then we have our accessory organs as well. And so we have things like the liver, we have the gallbladder tucked up underneath there, and tucked in behind the stomach, we then have the pancreas as well. And so all together, we have the gastrointestinal tract or the alimentary canal where we're going to do digestion. In order to move things through the digestive tract itself, we have essentially two ways of moving things around. Primarily for mass movement, we use peristalsis. And so we're going to move simply by having alternating contractions of the walls themselves. And so it's going to contract and contract and contract in a wave. And that's going to allow for pushing of the food product all the way along the digestive tract itself. We can also do alternating contractions where we squeeze back and forth and back and forth. And this is going to allow us to mix things up inside. And so this is going to be segmentation. And so this allows us to mix in the digestive enzymes, allows us to mix around the food itself so that it comes in contact with the digestive lining itself, so that we can then absorb it from there. So the GI tract itself, in terms of the structures that are within the tract, we begin in the oral cavity, swallow things back into the back of the throat, into the pharynx, from the pharynx down through the esophagus into the stomach. Hold things there for a little while in the stomach until we move into the small intestines, where we're going to do the majority of all of our digestion and absorption, and then into the large intestines, and then store it in the rectum for a period of time, and then out through the anus. And so all told, the entire tract itself is in the range of about 30 feet from beginning to end. And so all told, we have quite a long process for digestion and absorption to actually occur from there. We have certain areas where we're doing actual digestion and certain areas where we're just simply moving or shuttling the bolus of food along through the tract itself as well. When we look at the GI tract, we have essentially from the esophagus on down, we have the same four basic layers of tissue that are going to be found within the tract that's there. And so if we begin at the innermost portion, so if we were a piece of food kind of moving down through the digestive tract, we would see the mucosa. And so the mucosa is the portion that actually the food is going to touch. And so it comes in contact with it there. Along that esophagus as well, we have stratified squamous epithelium there. And so starting out with stratified squamous epithelium, beginning all the way up even into the pharynx, we're going to allow for protection from the food that's being swallowed down. And that's going to change in terms of the type of epithelium that's there, depending upon the area of the digestive tract that we're in. Deep to the mucosa, we then find the submucosa. And so the submucosa is going to be the next layer in the digestive tract itself. And so it's kind of the bluer area that is there, and that follows the next layer in. The submucosa itself is essentially kind of where a lot of the glands are. This is where we're going to have blood vessels for doing things like the movement of food from the digestive tract into the blood vessels themselves. And then from there, we're going to move into the muscular layer. And so we're going to move into the the muscularis out here. This is going to have two layers, and so there's going to be a circular layer and a longitudinal layer. Those two layers are found throughout the digestive tract itself again as well. The only place where we have an additional layer is in the stomach. And then the outermost layer is the adventitia or the serosa, and this is the outer covering. This is, in a sense, if we were looking at it from going into the abdominal cavity, this is what we would see on the inside. The lining of the mucosa itself serves a couple of different roles. And so beginning at the beginning of the digestive tract in the oral cavity, we need a lot of protection. And so it's going to provide for protection from the food products themselves, just the abrasion that is there. As we move further on down, we have relatively corrosive stomach acid. And so we have our hydrochloric acid inside there. We have digestive enzymes. So we're going to need protection from them as well. We don't want to be digesting our own cells once it's there. It's going to keep those things that may be living along the digestive tract out. And so we have defense against pathogens that are either resident pathogens or things that we may actually swallow down, things that may be growing on the food that we're eating that's there. And digestion is a highly mechanical process. And so we're going to have all kinds of potential damage occurring to the tissues just from mechanical processes. Up in the oral cavity, we begin the digestive process itself. And so with this, we have the oral cavity. And so into the mouth we go. And with this, we have essentially structures that are designed to mechanically break down food. And so the majority of digestion that is occurring here is going to be mechanical digestion. A little bit of chemical digestion in the form of breaking down some carbohydrates. And so the saliva produces some enzymes for that purpose. The oral cavity itself is bounded by all of the teeth. And so we have teeth on the front and on the sides. We also then have the gingiva or the gums, and that's going to help to hold food inside there as well. And then we have the cheeks, and so we have the buccal portion that is there as well, and that's going to help to keep everything inside as we chew things around. The tongue is going to be able to manipulate the food as it sits inside, move it in between the teeth, move it from side to side, keep it in between the teeth, and then help to eventually push it back down into the oral, further into the oral cavity and initiate the swallowing reflex. Rimming the back portion of the oral cavity is where we're going to find some protection in the form of tonsils. And so we have our tonsils way at the back here, and so we can see the palatine tonsils there. We're also going to have lingual tonsils and pharyngeal tonsils as well, lining the back there also. On the tongue, we have the tongue itself is really kind of under control of two separate nerves. So each side is kind of controlled by itself. But the whole tongue itself is held together in the center here by the lingual frenulum. And so that's kind of that little ridge that sticks up inside there as well. We're going to also have, to talk about it now as well, we're also going to have the opening for the submandibular duct right in there on either side of the lingual frenulum. And then continuing along the side of the tongue, we have the openings of the sublingual glands as well. And so those occur along the bottom of the tongue. The superior aspect of the oral cavity contains the hard palate. And so we have a bony portion here of the hard palate that's there. And so we have the maxilla and the palatine bones. And then we have the soft palate. And so the soft palate there made up of muscles and connective tissue as it extends down into the back of the throat as the uvula. So that continues on down there. That whole soft palate is going to be able to raise up during the swallowing process. And so that's going to close off the nasopharynx from the oropharynx. And so we have the ability to make sure that no food comes up through the throat and into the nasal cavity as it goes up through there. Clear that out. And so we again can see some of our tonsils back here as well. We have the palatine tonsils one more time back there. We can now see the lingual tonsils as they sit right in there. So the swallowing reflex itself uh, is initiated by our conscious movement of the bolus of food back towards the back of the throat. That's going to initiate an involuntary response, which then is going to be the rest of the swallowing process. And so that's going to cause the uvula and the soft palate to raise up. That's going to cause the epiglottis from the larynx to close down. So we've now closed off the nasal cavity and we've closed off the larynx from any food entering into either of those two spaces. And so the pharynx is going to push that bolus of food in towards the esophagus, and then the esophageal phase is going to cause peristalsis to move that food all the way down to the stomach itself. And so in the oral cavity, we had started mechanical digestion as well as some chemical digestion. The pharynx and esophagus doesn't have any kind of digestion occurring within it. The role of our salivary glands is primarily just to moisten the oral cavity. And so it's going to be for moistening the oral cavity. It's going to help to clean the oral cavity. It's going to kind of prime the digestive process beforehand. And so it's going to increase in its secretions during the kind of pre-meal period of time where we're salivating and things in there. And it'll also continue to salivate after the meal to help to kind of rinse things away. And so it's going to help to rinse those substances down as that goes along. The first portion of chemical digestion is occurring here in that we have the production of salivary amylase, and that salivary amylase has the ability to break down carbohydrates, primarily starches. And so we have that ability to do so there. The fluid that is in the saliva as well also has the ability to help to dissolve chemicals from our food so that we can actually taste it. And so anything that is occurring for taste and landing on the taste receptors has to be in a solution in order for us to taste it. Throughout the day, we produce a fair amount of saliva all day long. Most of it is getting swallowed down, and the majority of it is actually occurring during meals themselves. The glands that we have the parotid glands are the largest of the glands. These ones actually sit just in front of your ear. So they're kind of down by the ear lobe in a sense, kind of anterior and inferior to the ear itself. That's there. It produces a fair amount of the saliva that we have, and so upwards of a third of the saliva is produced by the parotid glands themselves. It produces a saliva that is productive during times when we have carbohydrates in our diet, and so when we have the need for amylases. They also will secrete when we have things that are sour, and so it'll increase its production during things that have a high acid content to them. The submandibular glands, now lying just underneath the mandible itself, and so essentially just kind of tucked underneath the body, just about at the angle of the mandible themselves there. The duct for the submandibular gland, as I said before, runs all the way up to the lingual frenulum and exits on either side of the lingual frenulum. The parotid duct comes out towards the back of the oral cavity by the second molar on the top and comes along and secretes out there. Lastly, we have the sublingual gland. And so the sublingual gland is under the tongue, as the name implies. This one secretes the least amount of saliva. This one produces a more thick type of a saliva. This is one that is more stringy. Think of like perhaps brushing your teeth and you have that kind of spit that kind of strings out and so on. That's oftentimes coming from the sublingual glands. Here again, we can see the parotid duct as it comes in and enters into the oral cavity by that upper molar. And then we have all of the sublingual glands draining out through there. The glands themselves produce saliva into the ducts that they have. And so depending upon the type of gland that we're looking at, they can have different types of cells that are present. And so those that are producing mucus, those that are producing more of a serous fluid, those that are producing a mixed type of saliva as well. The teeth are the portion of the oral cavity where we're going to do mastication. And so this is where we're going to be doing the actual chewing part, the masticating portion of the digestive process. The portion of the tooth that we actually see is the crown of the tooth. And so this is the part that is actually exposed there. Between essentially the gum line and the bone, we have the neck of the tooth. And then below the bone line, we then have the root of the tooth itself. That's there. Inside that root, we have the root canal. And inside that root canal, we have arteries, veins, and nerves, which is going to supply up into the pulp cavity here. That is there. From the pulp cavity, we move outward to the dentin. So we have the dentin portion of the tooth. This is a relatively soft portion to the tooth itself. And then the outermost portion that comes down through and along the root, we have the cementum. And connected into that cementum, we have a series of ligaments. And so we have all of these ligaments that are going to help to hold the tooth in place. These are the periodontal ligaments. You can remember back to when your teeth were potentially falling out as a child, and sometimes they kind of got stuck on what felt like almost like a little thread or something, and typically that was either connective tissue or the periodontal ligaments where they were still kind of holding on in that region there. The teeth have a relatively tight connection into the bone. In terms of the joint, this is a Gomphosis joint, so very little movement or no movement whatsoever within the joint. We get two sets of teeth, and so in terms of the teeth themselves, we start out with 20 primary teeth, and so these are the milk teeth or the deciduous teeth or the primary teeth. They erupt at pretty regular periods of time, typically beginning at about 6 months. And so we'll get those first teeth coming out somewhere at 6 months, but some babies are a little bit slower to grow their teeth, and so they could be even a year. Some babies are born with teeth. So it all just depends upon the particular individual themselves. And then they also start to fall out at fairly predictable rates as well. And so usually the bottom two central incisors are the first ones to come in, and then you get the top two, and they're going to fall out and be replaced at about the same rate. And so the bottom two teeth will fall out first, and then the top two teeth. And then we'll come back to the bottom here, and then we'll go to the lateral incisors, and those will fall out. And then we'll come back up to the top, and then the lateral incisors on the top will fall out. And so on and so forth as those teeth continue to come in and come in and come in as they go along within the teeth themselves. All the way until the last teeth to become exposed, those third molars. And those third molars, or the so-called wisdom teeth, these ones are teeth that are oftentimes needing to be extracted because our jaws are getting smaller. Sometimes people don't even happen to have those teeth on those. Moving from the oral cavity, we move back into the pharynx. And the pharynx and the esophagus are both going to be just simply a passageway for the food. It's a way to get the food from the oral cavity all the way down to the stomach. And so no digestion is really going to occur along the way. This is just simply a passage for the food to get from one spot to the next. That's there. As the food starts to come into the stomach, there is a series of sphincters that are going to keep the food from moving back from the stomach back into the esophagus and causing regurgitation. That's there. But when that does occur, because the sphincter does not hold tight, this can sometimes lead to heartburn or reflux or GERD, gastroesophageal reflux disease. All those kinds of things can occur because of that reflux from the stomach back into the esophagus. So now down into the stomach. So the esophagus enters into the stomach at the cardia. We then have a dome-shaped portion of the stomach called the fundus. The majority of the stomach is then the body. We then taper down to the pylorus, or the pyloric region. And the pyloric region here has a sphincter that is going to stop food from exiting the stomach before the duodenum, the first part of the small intestines, is ready for it. And so this is where we're going to store food until the food is ready to go to the small intestines. And so depending upon the food content, food that is more fat laden is going to stay in the stomach longer. Food that is more carbohydrate rich will leave the stomach a little bit faster. 4 things there. The stomach has a relatively low pH, and so all of that lining inside the stomach is being subjected to a pH of about 2. And in order to keep it safe, all of the cells that are lining the inside of the stomach have a mucus that covers over them. But even with that, the cells are going to be replaced in less than a week. And so a very high turnover rate of all of the cells inside the stomach itself. The food, that bolus of food that came down from the oral cavity into the stomach, as it gets mixed back and forth inside the stomach, this is going to lead to a substance that we call chyme that is going to be released from the stomach itself. Inside the stomach, we have our mucosa here. And so the mucosa contains within it what we call gastric glands. And so we have these glandular tissue that are down deep inside. In order to get from the gastric glands out to the outside of the stomach in terms of the lining, we go through a gastric pit. And this is where our hydrochloric acid is going to be produced, and hydrogen ions and chloride ions are going to be moved out onto the surface, and they're going to join together to become the hydrochloric acid that is there. Deep to the mucosa, we then have a submucosa, and so lots of blood vessels there as well, lymphatics, nerves, all kinds of things running through there. The next layer is in the stomach, actually 3 layers, and this is muscle. And so we have the deepest layer closest to the mucosa. We have the oblique layer of muscle. We then have a circular layer of muscle, and then we have the longitudinal layer of muscle. And so the longitudinal layer of muscle is running along this way. The circular layer is going across this way, and then that oblique layer is coming across this way. And so this is going to allow us to mix all of that food up, that bolus of food, up into a bolus of chyme to get released into the small intestines. The organs themselves, as they sit inside the abdominal cavity, to a certain degree, they're kind of just hanging around, so to speak. And so there's not a whole lot that helps to hold them into place. But what we do have is mesentery. And so mesenteries are the connective tissue kind of coverings that we have here to help to hold things in place. They contain a large amount of blood vessels. They have nerves. They have lymphatics. This is going to be fat laden in through the mesenteries themselves that are there. And that's going to serve as energy storage. We're going to have a lot of adipose inside there. Different portions of the mesentery help to hold different places. And so we have things like the lesser omentum going from the stomach to the liver. We have things like our greater omentum, which covers over as kind of like a sheet covering over the digestive organs themselves. Going in between the loops of our small intestines, we have the mesentery proper. And then covering the wall of the abdominal cavity, we have our parietal peritoneum. And then covering the organs themselves, we have the visceral peritoneum. The small intestines is the longest portion of the digestive tract itself. This is where all of our chemical digestion is going to finish up. We're going to add a large amount of digestive enzymes into this portion of the digestive tract. And so it is quite long, upwards of 20 feet in terms of its length, coiling back and forth, running all the way from the stomach down to the large intestines and entering into the large intestines at the cecum. The small intestines is divided up into three different portions as it makes its way from the stomach, from the pylorus all the way down to the cecum. We go through the duodenum, the jejunum, and then through to the ileum to make it all the way through to the large intestines there. The duodenum is the shortest portion, and so this is the first segment here. And so this is a little bit less than a foot long in terms of its length. We then move through the jejunum. This is the middle portion of the digestive tract. This is where we have a large amount of the digestion occurring here. The duodenum does do some digestion. It begins the process of digesting lipids, which is part of the reason why lipids take a little bit longer to exit the stomach. And then the last portion of the stomach, again, kind of finishing up all of the chemical digestion that we have, is the ileum. The ileum comes up to the large intestines at the cecum and enters in through the ileocecal valve. That is there. The small intestines, with the jejunum and the ileum, they have the ability to kind of wiggle back and forth as food is moving through them. And so you hear a lot of the gurgling, and you may even see some movement on the abdominal wall when the small intestines are actually contracting. In order to absorb food, we need to have lots and lots of surface area. And in order to make that surface area, all along the small intestines, we have what we call villi. And so we have these villi that extend up on here as circular folds. And then we have little individual parts that stick up there. And then on all of the cells, we have little microvilli that are going to add to the surface area as well. And so increasing the surface area as much as possible so we can absorb every little bit of substance that we have within the digestive tract itself. That's there. And that's going to run along all of the small intestines. But when we look at the small intestines with the naked eye, we won't even really see the circular folds. They're going to be too small to really see. It's just going to look like it's a nice smooth surface. But they are, in fact, increasing that surface area as much as possible. Into the large intestines, food comes from the ileum, and that's going to allow for the last portion of digestion to occur for some of our nutrients, primarily things like vitamins. And so we have a large bacterial load in the large intestines, and that helps with the breakdown of some more of our foods to liberate some of the vitamins that we may need from them. But the primary job of the large intestines is to reabsorb water and electrolytes from the food that is coming through. And so we've spent a lot of time dumping things like saliva, intestinal juices from the intestines, stomach juices, we have gastric juices there, we have enzyme secretions coming from the pancreas, and we have a large amount of water that's going to have to be reabsorbed from the large intestines. This is part of the reason why if we develop something like diarrhea, the amount of water that is being lost there needs to be replaced. And so if we're losing all of that water, we're not reabsorbing it. That's coming from the digestive tract itself mostly. It's not actually coming from the food that is still there. So we need to be able to absorb as much as possible there. The large intestines is going to loop back up from the right lower quadrant and back up to the right upper quadrant, over to the left upper quadrant, back down to the left lower quadrant, and then move in towards the pelvis. That whole journey is roughly in about 5 feet or so, making its way along the path there. So we have beginning at the cecum. We then go up the ascending colon. We come to the right colic flexure, across the transverse colon to the left colic flexure, down the descending colon to our sigmoid colon, and into the rectum. At the rectum, the feces is going to, in a sense, rest there, and it's going to become compacted and ready for defecation out through the anal canal once it's there. That process all along the way has allowed for the removal of the majority of water along this process so that we have a relatively dried out fecal matter at that point. The couple of extra things that are on the large intestines, we have the appendix or the vermiform appendix extending off of the cecum. There's also some little, what almost looks like dripping fat along the large intestines as well. These are the epiploic appendages. And then the last little difference that the large intestines has is in the musculature. The longitudinal muscle is arranged into kind of thin little ribbons called tinea coli. And those tinea coli run the length of the large intestines there. Our accessory organs, we begin with the liver. We have our largest solid organ that we have within the body itself. The liver is divided up into two major lobes, the right lobe and the left lobe, that are there. Those lobes are separated by ligaments, and so we have ligaments that come up onto them. That is there. The liver is very, very vascularized, and so we have a large amount of blood supply coming to it. Part of that blood supply is coming from the digestive tract, in that we have the portal vein. And so this is blood coming directly from the digestive tract. And then we also have the hepatic artery that is going to bring blood over to the liver that is oxygenated. So we have venous blood and oxygenated blood from the arteries, both coming to the liver. The liver is then drained by hepatic veins, and so both the portal vein and the hepatic artery proper drain into the hepatic veins, which then eventually drain into the inferior vena cava. The liver is highly regenerative. It even has the ability to regenerate if part of it has been removed. And so we can do a living liver transplant where we take a portion of the liver and remove just a portion of the liver and give that to the recipient. And then in that donated person, that liver will regrow over the next several months. Functions of the liver are one of the more important things that it needs to do is to produce bile. And so we're going to produce bile. That bile is going to have all kinds of bile salts in it. Inside the gallbladder, it will be stored. This is going to be our main way of getting rid of bilirubin from the body. So we have to be able to get that bile out of the body in such a way with the digestive tract. So anytime we have lipids, the gallbladder is going to contract and deliver them to the small intestines. That's there. The liver produces a large amount of proteins. And so those proteins that lie within the bloodstream are being produced in the liver itself. The liver can store fats, and so it can process fats that are going to be brought into the through the digestive tract, and so we can deal with fatty acid concentrations here. We can store glucose as glycogen inside the liver. The liver is also going to deal with detoxification. And so we're going to have to remove any kind of toxic substances that have potentially come in through the digestive tract, been delivered directly into the bloodstream, or come in through the skin or even the respiratory tract as well. And so drugs, the metabolites of those drugs, different poisons, all of those things are going to be metabolized by the liver itself. Things that are fat soluble can be stored away inside the liver as well. And so we have our fat-soluble vitamins can be stored here within the liver. We can also have our reserves of iron stored here as well as we break down red blood cells. The liver, as I said, produces blood plasma proteins. And so these plasma proteins are important for delivering different substances within the blood itself. We talked a little bit about albumin when it comes to the maintenance of water levels within the bloodstream itself. That's there. We're going to deal with red blood cells. And so just like the spleen, we have the ability to eliminate any kind of red blood cells that may have become damaged or destroyed within the bloodstream itself that's there. Anything that may be coming in from the digestive tract that may be foreign, the phagocytes of the liver will deal with those as well. And so we have Kupffer cells that kind of wander around the liver, wandering for things that shouldn't be there. So the liver produces bile, but that bile is going to end up into the gallbladder. And in the gallbladder, it's going to be stored until it's needed during digestion itself. The gallbladder is going to not only store the bile there, but it's also going to concentrate it. And so it's going to make it more and more concentrated over time, which means that we have the potential for the formation of gallstones. And so if we over-concentrate, or if we have an excess amount of some of the salts that are inside the bile, we may form stones inside there. Those stones may then become trapped along the biliary tree, along the vessels that are the ducts that are going to bring it to the small intestines that is there. Oftentimes the cause of gallstones is excess cholesterol that's there. And so the duct that brings bile to the gallbladder is the cystic duct, right in there. We then have the hepatic duct bringing bile in as well. And so we have the common hepatic duct. And then we have the common bile duct that's going to then deliver that bile down to the pancreas. And so here we can see the left and right hepatic ducts joined together to give the common hepatic duct. The common hepatic duct is going to then branch off and give us the cystic duct, which goes to the gallbladder. And then coming down as the common bile duct, and that common bile duct is actually going to join a duct coming from the pancreas called the main pancreatic duct, and the little short portion here where they're together is going to be the hepatopancreatic ampulla. And so this is going to open up into the duodenum. And so as bile is needed, that bile is going to be sent through the ducts from contractions of the gallbladder and send it through the cystic duct, down through the common bile duct, out through the hepatopancreatic ampulla, and into the duodenum. There it can start to emulsify fats. We can start the digestion and absorption of fats within the diet itself. Lastly, we have the pancreas. And the pancreas is going to be a dual-purpose organ. It has both an endocrine and a exocrine function. And so the endocrine function is dealt with by pancreatic islets or islets of Langerhans. The exocrine function is dealt with the majority of the tissue. And so we have pancreatic cells or acinar cells that lie within the pancreas itself. All of those exocrine cells produce their enzymes that are going to end up into the main pancreatic duct, going to be joined by the common bile duct into the hepatopancreatic ampulla. And then it also has this little branch off here called the accessory pancreatic duct, where we can just get pancreatic enzymes coming out as well. The endocrine function, we'll talk about during the endocrine chapter, but the endocrine function comes in the production of insulin as well as glucagon. And so the majority of all of the exocrine function from the pancreas is going to give us the enzymes that we need for proper chemical digestion within the digestive tract and allow us to have absorption.